Hello, everybody. Welcome to this session at the Beat Conference. This is Navigating Treatment Teams and Services, practical tips for engaging in the process and ensuring the best outcome for you and your family. So slightly oddly, I'm pre-recording this session a little in advance of the conference, but there will be time at the end for you to ask questions. And what I'm going to do now is I'm going to put a presentation up that I put together for this session. So if I could just introduce myself first. My name is Alan Lofthouse. I am a Beat ambassador. I'm also an Echo coach, which is a thing that Beat offers for some parents, which is a phone call every week for about 24 weeks and a chance to talk in a coaching way about the experiences that they're having supporting a loved one with an eating disorder, and for me to help guide them through that difficult journey. I'm also a parent carer and a dad to my daughter, who suffered for 4 years with anorexia nervosa, going through various different treatments from a community-based setting into an acute hospital, back to the community setting, back to a different hospital to a more specialist hospital, and then through into a recovery which they've been able to maintain now for around about 3 or 4 years, which has been fabulous. So I'm going to start here with a kind of set out our family journey, really, because I remember very clearly the first day we accessed services and went to the GP. In fact, a couple of GP visits, as people are quite aware of. And in fact, early on, it was somebody at school who raised a concern with us that potentially our daughter had been losing more weight at school, and we hadn't noticed. So we sort of set out to our GP, not really knowing what we were expecting, and the GP said, you know, this may be an eating disorder, not sure, going to refer you for a specialist assessment. So we went into the specialist assessment centre, and within about half an hour, our daughter was in a wheelchair, being wheeled and being told not to exert herself because her heart might stop. And as parents, I can still remember the feelings that evoked in us. So for us, what we thought was, well, this is just a standard type of illness. I'm sure we didn't know much about it. Nobody that we knew in our family had suffered before that we knew of. So there's our top, the person on the bicycle. We're going to start from here. It's going to be a couple of months of treatment, and I'm sure we're going to get to the end and all will be well. And of course, all the best laid plans don't quite work out. As you can imagine, the reality of our journey was much more difficult. The highs and the lows, the difficulties, the challenges, the setbacks. But if you really think about it, our aim was still the same. We were still aiming for a recovery. And hopefully what I will cover today is some tips, some reflections about our journey that might help other parent carers or even people who are in the treatment services themselves understand the position that parents come from when they're supporting their loved ones with an eating disorder. So I want to cover a couple of big issues in terms of the feelings that myself and my wife had very, very early on at the outset of this illness. And the first question and the first thing we had to deal with was guilt. I'll be really honest with you. The thoughts that were going through our head at the time was, what did I do to give my child an eating disorder? And as you can imagine, those kind of thoughts aren't particularly helpful, but they felt necessary at the time. We spent a lot of time wondering what exactly it was that we did. What did we say? What didn't we do? How did we not spot it soon enough? And all the while we're there pulling these great big balls of guilt around with us and wondering what's going on. And that got in the way of us being able to access support and being able to really engage in a way, the most constructive way with services right at the outset. So then the other thing, of course, is fear and stigma. The stigma being, well, this doesn't happen to my child. You know, mental health illnesses happen to other people, not to us. We didn't really have much experience in our family about this that we knew of. And of course, probably back in earlier times, people didn't talk about mental health quite the same way they do now. And then the other one, I think the big one that certainly drove us very early on in terms of the anxiety and panic response that it can bring out in parents, is that your genuine fear is that you're going to see your child die. And as many of you will know, the statistics for eating disorders are that is a life-threatening illness. So we weren't, you know, it's not an unreasonable or it's not a fear that you should take lightly, but we were still, that was something that got inside of us, and we were thinking that this is what's going to happen. And of course, the fear response and anxiety responses mean that the way you interact with healthcare professionals, the way you interact with your family, your people at work, is all very much influenced by those things. And I guess the ultimate goal, the thing that all parents are trying to do, and what these things can get in the way of, but it's what you've got to keep coming back to, is that there are times when this illness will take away all the hope from your loved one that they can or that they should get better. And as parents or as loved ones or as grandparents, whoever it is in that family relationship, the thing that we held on to was the hope. And it was the hope of recovery, and it was the knowledge that we're going to get there. We don't know how long that's going to take. We don't know what steps we've got to go through to get to this mythical recovery that we were looking for. But we did know, above and beyond everything, that we were holding on to hope for our daughter, that she would be able to recover. So in terms of people accessing services at the moment, I pulled a couple of things from the internet that I think are relevant, and I've stayed away from the sort of scare tactic headlines. But what we do know is that the NHS is under extreme pressure at the moment. It's been through a 2-year pandemic and still trying to recover, still trying to restart the services that were stopped. And during the pandemic, when people weren't really able to meet, all kinds of things like accessing family-based therapies were more difficult. Things were done online. The way we as parent carers interacted with other parent carers within our community services was more difficult. So the NHS did a sterling job of rising to that challenge. And in December 2020, the Royal College of Paediatrics and Child Health warned parents over the holidays to be alert of the signs of eating disorders, with mental health getting worse for the general population. The numbers of eating disorders and people accessing services did increase. But NHS England have set out that they recognise this, and that they're going to put in place gold standard, as they call it. And I've pulled here is some nice guidelines, and it's the access and waiting time standards for young children and young people with an eating disorder from 2015, and they were supposed to be in place by 2020 and are measured. So this applies to children and young people up to the age of 19. And what it says is that 95% of those who are referred for assessment or treatment for an eating disorder should receive the NICE approved treatment outcome within 1 week in urgent cases and 4 weeks in routine and urgent cases. And in our example, and in the place in the country where we live, which is down in the lovely county of Dorset, we had a community team. We saw the GP, we were referred fairly quickly into the community team. And that was a brilliant service that we're very grateful for. But we do recognise, and in my role as a Beat ambassador and as a Beat carer, I speak to people who don't have that. And there is a postcode lottery, depending on where you are in the country, depending on the GP services in the area, depending on whether it's community-based or not. People have a very, very different experience, including across England, Wales and Northern Ireland. So just in terms of a reassuring thing, I hope all of you know of Eva Musby, and she's written a fabulous book, which is Anorexia and Other Eating Disorders, How to Help Your Child Eat Well and Be Well. And what she says is, here's a tip I've heard from both our GP and our eating disorder specialists. If a parent thinks their child has an eating disorder, they're most probably right. So this is a thing to say, trust yourself. And as parents, once we clocked on to what was in front of us and we tried to overcome the fear, the stigma, we realized we had an eating disorder on our hands, and recognizing that and then convincing GPs and others was the tool that we did in terms of supporting our loved one to gain treatment and accept help for their eating disorder condition. So what are our early lessons really about entering treatment? Well, the first one is not delaying to get help, and that's easier said than done, because the fear and the stigma can delay people accepting and thinking that this is just some sort of phase that our daughter or son is going through. And I'm sure, and if you go and speak to the young person, they'll tell you they've never felt better. So you can delay by weeks, and even entering GP services, you can be palmed off a number of times by GPs. That's the experience that I've had shared with me. So there is something about not delaying getting help. Also reading the right books, because that fear that I described at the beginning can be echoed in books. And so there is a beat reading list that I can highly recommend. And the two books that I read were the Janet Treasure book about caring for loved ones and the Eva Musby book, both of which I would recommend because they have practical helps, practical guides and practical advice for parents that's not there to scare you or to bring out more fear response, but to get you to take the illness seriously and to try and find help and know how to manage that help, and some of the tips of going through the services. And the ultimate aim of the early entering of treatment is to try and normalize weight. And when we accessed services, our daughter's weight was on a downward trajectory. And we didn't really realize that you can't suddenly turn that up. There's going to be a slow loop. So actually, she did get worse before she got better. And her weight dropped even more, even though we suddenly accessed services and we thought, great, this is going to suddenly change everything. Well, it doesn't. Weight can be on a downward trajectory and it needs stabilization. And it also, you as parents, you as grandparents, you as friends or loved ones are going to be helping the young person to normalize their eating patterns. And that's something that's going to take weeks and months and maybe even years to do. That's not a quick fix. So some of this is about slowing this down. And the other thing we're trying to do as parents and the treatment services is to retrain the brain to be more flexible. And that in itself is a whole plethora of different training and techniques and tips. And it's amazing how, as parents, we realized how sometimes inflexible our thinking was and how much we were modeling the wrong way of thinking about eating and about food. An early lesson from us as well is that although our daughter got more and more unwell and ended up in an acute hospital and a paediatric ward, it wasn't the ward's job to cure her of anorexia. That was a far more complicated thing. And in fact, all it did was get us out of a very dangerous place. It relieved the fear of our daughter's going to die, because the hospital weren't going to let that happen. The eating disorder service were committed as well to not letting that happen. So as parents, the hospitalization was helpful, but we were there every mealtime. We were there feeding, and we were there not curing the anorexia, but supporting our daughter to regain weight, to retrain her brain to be more flexible, to normalize weight and normalize her eating patterns. And then the other thing is an early lesson is, you can't trust the illness. I said earlier that our daughter was very convincing in terms of, I've never felt better. Young people with the starved brain can feel this extra bolt of energy, which if you look at the research is part of the starved brain, where it's throwing in a lot of energy to sort of get you to a point where you can eat. And it's temporary, and they will drop, and they'll sort of crash soon after that feeling of elation. But there is early on, and when you're entering treatment, you've got to kind of separate out the eating disorder from the behavior of your child. I had put there before, know your enemy. Your loved one or your child is the one you're looking out for, and the illness is your enemy, and it will try and lie and manipulate you. So you need to be really wary of that. And that can also happen to the treatment services. I'm sure when you take your loved one in, your loved one will tell them how great they feel and how they don't really need any help. And this is parents worrying, and it's all just a phase. And then the other early lesson of entering treatment is our skill set. So, we were parents. We feel we were good parents when we really reflected. We hadn't done anything wrong to bring the illness on. But we recognized all those skills that we had, that we raised our daughter from a baby, were suddenly not working anymore. We couldn't just serve the food. She wouldn't just eat the food, and it was constant conflict. So not only did we want a medical cure for this, which we suddenly found was a much more long-term thing, but we needed to develop new skills. As parents, we need to skill up, and we need to learn techniques, and those techniques are in the good books, and they're available from your local eating disorder service to help you as parents to navigate and to learn. So I think some of the most important things for me in my learning and reflection was about these animal models, which many of you will know. And when you're accessing treatment teams, there's no difference in the animal models, in the way that you can behave and the way that parents can interact with healthcare professionals. And at times, there is a need to be a rhino. If your child is suffering heart palpitations because they've lost so much weight that their heart is unable to work properly, you need to go to an A&E, you need to get help, you need people to take you seriously. And sometimes the rhino is the right animal model for that. And at other times you need to be the kangaroo, the loving, we're going to take care of you, don't worry, reducing the fear, reducing the anxiety that your young person is suffering. But overall, it's the dolphin, it's that middle model, it's the swimming alongside your young person through treatment. And that goes for the early part, but also the later part. And I think one of the things that we as parents reflect on now is we were too keen too quickly to get involved in the psychological therapies, when early on what was really needed was steady, gentle refeeding, a bit of medicine at the beginning to get the brain ready to be flexible enough, because a starved brain isn't really very good in therapy. And actually, I think if we did this all again, that's one thing we'd probably do, is slow down, less rhino, less kanga, and more dolphin around the psychological therapies to get to the point where they're going to be more effective. Now, I pulled this from a presentation by an American pediatrician who was talking about paradigms, and this is where something shifts from one state to another. And this is how parents and carers were viewed in the old world, if you like, and what they thought was eating disorders are a result of control and boundary issues in their young people. And I love this term, parentectomies, which is the removal of parents from young people, was helpful. And only once you do that can you start to have insight into the illness. So that's what they used to think, that parents were part of the problem. And so often we were excluded or pushed away from services. I have to say that's not my experience, but that's the old way I think these illnesses were treated. So the new way it's treated is that there's much more acceptance that eating disorders aren't because of parental control or parental behavior, but they're down to some sort of biological or genetic vulnerability. And that we are the best allies for the young person and for the services that they are in to get their recovery. And as I said, nutrition first, insight later. Get them refed, get the brain more flexible, and then the psychological processes are more able to work. And that certainly fits with my reflections on the illness. So this is a very busy slide here, but this really is about what the providers of eating disorder services should do. And there's 8 things, and I'd recommend you can find this on the Beat website. But what these really tell you as a parent or a carer or a loved one is that there should be optimum involvement between you and your loved person, and that the service staff themselves should be trained about the impact and the importance of having carers as part of the recovery. And I'm really so pleased with Dorset's eating disorder service, because they've really harnessed parents and carers to deliver training to help parents gain new skills, to share their experience, to put an arm around the shoulders of somebody who's going through the early stages of the illness and to give them some hope. And we're really so very, very important to do that. And as well, number 5 there is about peer-to-peer support, because the ECHO program run by Beat is a really important part of that, where we're able to give one-to-one support to people in a coaching way, not just as a way of talking about the emotions, but actually trying new skills. This illness loves getting people caught in traps, and you become so fearful of making changes because that might upset a status quo, and your loved one might begin starving themselves again. But actually that's a trap in itself. So learning and sharing is really important. So I think my takeaway would be to go away and read these and think about them if you're accessing your services, and if you're providing a services, how well do you meet those 8 points, because I think they're all equally important. Now, the Academy of Eating Disorders World Eating Disorder Healthcare Rights also give a number of really important rights to parents, but also to people who are loved ones and people who are suffering. So it's about respect, respecting the person and respecting their rights. It's about having informed consent. And there are times when your young person will not want you involved and know about their treatment, and that is a difficult conundrum. And really, the more dolphin I think you are in the way that you approach the services, hopefully the more likely your young person is to keep you alongside them as an ally rather than seeing you as not. But don't forget, it's the illness that will try and push you away. They also suggest that parents and carers should be a part of they should be participating in treatment, they should be communicated, but also balancing that against the privacy of the young person. And really equally important is carers need support too. And if you read all the books about the Janet Treasure book, it will talk about how to look after yourself and how to make sure you're not burning yourself out and end up with carer's fatigue. So here are my tips and personal reflections, which I hope are useful to you. The first one is it's a marathon, it's not a sprint. Early on, we set out with this maybe naive idea that 3 to 6 months, maybe we could go, even had a holiday planned at the end of it, all of which fell because the recovery, we were trying to recover too quickly. So if you're running a marathon, you slow down, you get your pace right, and you don't burn yourself out too quickly. You need other people. The cycle of change is a really important part of this, because those of you that will know the cycle of change will probably know that right at the beginning, when you access services, your children are in a state called pre-contemplation, where they don't really see that there's even a problem there. Whereas you are on the other side of that cycle of change in motivation and action. You want them to gain services. You want them to go and engage with the psychotherapist, the psychiatrist, the psychologist. And so that tension between where you are on that cycle of change and where your loved one is on the cycle of change is a barrier to them accepting treatment. So in some ways, you've got to find a way to get them from pre-contemplation, there is no problem, I am fine, to, well, I wonder what this illness is doing to my life and how it's restricting my life. I wonder if there's a problem. You've got to try and create curiosity in your loved one to look at whether they should be getting help and what that might look like. The third bullet point there is love with limits. It was some advice we got from a family therapist in the treatment centre, and we're very grateful because that's really stuck with us. This love with limits is, the illness will be vile to you. It will swear at you. It will try and lock you out of decisions, and all the while your loved one is behind that illness, being taken further and further away from you. But you're still parents. You're still able to exercise parental control to a point, depending on their age, of course. But there's no good in coming alongside the illness and collaborating with the illness against your loved person. So love with limits is a mantra that we stuck in our mind, which is, there are consequences sometimes to the behaviors, but those behaviors need to be punished in a way that punishes the illness and not your loved one. It's a really complicated part, but it's really important. In terms of the services that we accessed, the thing we told them is, look, you know the illness, but we know our loved one. So when you access services, the people you're dealing with will know the illness. They should know the illness and help you to learn and understand what the illness does. But you're the ones who know your loved one. You know what they were like before, and you know what they're like between. And when they present weirdly to the eating disorder services, there is no problem. I'm fine. My mum's just worried. My dad's just worried. I see no issue. You're the ones who know what's really going on. So trust yourselves and convince the services that they also can trust you, and you know what you're talking about. And really what we're trying to do is, throughout all of this journey, is we were becoming expert parent carers. We were the ones that were skilling up, and we were learning our enemy, the anorexia, and we were gaining the skills that was needed to confront the illness whilst also loving our young person. And we didn't get it right a lot of the time. In fact, we got it very wrong a lot of the time. But each time we got it wrong, we learned something, we reflected, we moved on. And it's no one's fault. I said right at the beginning about the fear, the anxiety. It is no one's fault, this illness. It comes into people's lives completely unexpected. But what we need to do as parents is model self-compassion and self-care. We want them to be looking after themselves, to love themselves more than they do, to be able to say, it's okay, it's the best I can do, rather than running through these perfectionist traits. So if we're going to ask that of our young people, we need to model it ourselves. So the things that we did were, we would engage in activities that looked after ourselves. So that might be going for a walk, going on holiday. A lot of parents that I speak to couldn't imagine going on a holiday, but actually we arranged it. So we went on a holiday, and my wife and I, to show that actually what we need to do, that this illness has an impact on us. Not you as the young person, but the illness does, and we need to look after ourselves to care for you. That's a really important lesson that your young people will take away, and try to stay involved in care and therapy decisions as much as possible. Again, the illness and your therapist will give you better advice about how that is done on the long term, and what to do in the event that the young person says, I don't want anyone to know any more about my illness. It wants secrecy, it wants privacy, and those can also be very dangerous things for it to have. And then our lesson really is, at one point, our daughter spent 6 months refusing even to speak to us when we visited a unit or even engage in the therapy. So, hey, as parents, it's free therapy. Go and take it. Go and find out more about yourself. Not, like I say, about what caused the illness, but actually, what is it in you that means you're not able to model self-compassion or self-care? What makes you, what are the things that you could be doing to help yourself be a better support to your young person? So I'd say it's there, use it. And there are some brilliant therapists and people working in these eating disorder services. So here are some references that I've used that I'm sure when these things are going around that you can have a look and read some of the sources that I do. But I highly recommend the 2 books, which are the Eva Musby book and also the Janet Treasure book, which are both with me here. So there's the skill-based training one with the dolphins on the front. And then this one here is the anorexia one, Eva Musby. So I'm going to stop this presentation now. And then through the magic of science, we're going to go to some questions potentially. Thanks, everybody.